CataractCoach.com podcast series, episode number 92, with Dr. David Kang from South Korea. The future of corneal refractive surgery is now. Welcome back to our Cataract Coach podcast. And today I have a very special guest, my dear friend, Dr. David Kang from Seoul, South Korea. And we're going to learn a lot from him today. And you're going to be really surprised, especially if you're a USA surgeon. David, welcome to my podcast. Thank you for doing this.
Well, thank you for having me, Uday. It's a big honor to be here.
We've learned a lot from each other. I've seen you give incredible lectures on the podium in many different countries over many different years. And I'm always impressed because sometimes in the USA, we don't get technologies because of the FDA as fast as you do in other countries.
Yes, that is true, but it's also much safer to go that way.
It can be. I can see both sides of the equation. Now, yeah. I'm in my surgery center, or our shared surgery centers in Beverly Hills, and Beverly Hills is like a big, empire of plastic surgery. But there's a place on the planet that's even more advanced, and where plastic surgery is more popular, and that has to be in Seoul, South Korea.
You're absolutely right. I mean, K-beauty after K-pop, and then all these plastic surgery clinics. In fact, in my building where my clinic is, there are 15 plastic surgery clinics in just
the one building.
Yeah.
Wow, that's more than Beverly Hills in a single building. That's crazy.
Yeah, it is.
But they're also pushing the envelope. So some of the beauty treatments that we see now in the US or in Beverly Hills for plastic surgery, actually started there in Gangnam like years ago.
Yeah, that's true.
So I always wonder, like, okay, I don't know much about plastic surgery. I'm just an ophthalmologist. Mm-hmm. But does that also apply to ophthalmology, particularly things like refractive surgery? Because plastic surgery and refractive surgery kind of go hand in hand.
Actually, you're right in a way, because most of my patients come referred to me after blepharoplasty. Blepharoplasty is a sort of a national sport over here in Asia. And then they come for their refractive procedures on the cornea or phakic IOLs, which are, amassing huge numbers here in Asia because of our levels of high myopia. So you're right. In a way, cosmetic surgery and refractive surgery do go hand in hand.
Now, it's interesting you brought about, the incidence of myopia, because I've seen here in the U.S., since when I was a kid, very few people were myopic. But now when we see every 3, 4, 5-year-old little child on a cell phone or an iPad from like birth, incidence of myopia now is very high. In places like in Seoul, it's like half the population that's young is myopic.
Well, it's not just in Seoul. Recent studies have shown this worldwide burst of myopia all over the world, in the US, India, Far East, even Europe. So, I mean, Steve Jobs certainly did a big job there.
Yeah, because I see little children, like 3, 4 years old, in a little stroller, just sitting there playing the phone at a focal distance of like 20 centimeters, maybe even 10 centimeters the whole day.
Right. And I've recently, I think, saw in the news, I think it was Australia, that they actually banned smartphones from school until 14. So children were not permitted to look at a smartphone within the territories of the school until they were 14 years old. And this is quite interesting because some of the enhancement cases I get, let's say I did a LASIK about 5 to 10 years ago. He or she comes back with increased myopia. And what's really funny is the curvature hasn't really changed, but there is more axial elongation.
Oh, axial lengths get longer.
Yeah, even in their 20s. I mean, this is something that's happening by looking at all these phones.
And it's interesting because normally you would think, at least I would think, that, okay, by the time you're 18, 19, 20 years old, the axial elongation is finished. But then that may not be the case. You may get increasing in axial length even in your early 20s or mid 20s.
Yeah, I mean, I don't know whether it's an ethnic thing, But
Okay.
I think definite increase near tasks like looking at a smartphone does something to our ciliary bodies and the sclera and promotes actual elongation. I mean, we're trying to do a cross-sectional study on this to look at all the patients that we've enhanced in the last 3 to 4 years to compare their curvature, axial length, epithelium, and all other barometers like lens thickness, chamber depth, and to see where this is going and what's evolving.
Yeah, I mean, certainly there's some science behind, and we've known this for many years, that prolonged near stimulation causes the eye to grow to emphasize the near vision.
Mhm.
But I think, wow, I think we're all a bit surprised that, yes, you can see this even happening up to mid-20s.
Yep, up to mid-20s.
So if you have a patient, let's say, who had LASIK done when they're 20 years old
Yep.
for some degree of myopia, now and at the time of age 20, they became plano or emmetropic.
Mhm.
Now you see them age 26 and they're -1 or 2 again. What's your preferred method of enhancement with a prior LASIK flap?
If it was a femto flap, which I try to do all the time, then I would have no schemes, no problem in relifting that flap.
Right.
Sometimes the flap doesn't want to lift. I would make another bigger flap on a
Bigger
flap.
and deeper.
Yep. And if pachymetry wouldn't allow it, then I would perform a surface procedure.
Oh, PRK or trans PRK.
Trans PRK.
Yeah, that makes a lot of sense. Yeah, I agree with you. I have not done a microkeratome based LASIK in, I don't know, maybe 10 years. I hope I still remember how to do it.
Oh, your hands remember.
Because for the young surgeons, because our podcast has surgeons of all ages,
Yeah.
ages late 20s to late 70s. But most of our listeners tend to be in their 30s and 40s. You don't know what you escaped. When we first started doing LASIK with these mechanical microkeratomes, you put this suction on the eye. They got the IOP of the eye to like 90. So high the IOP, the patient's vision just went dark or grayed out.
Yeah.
Then you had this mechanical oscillating blade going across the cornea, and it blocked your entire view. So you had no idea what was happening.
Exactly.
And when the blade finally returned and released, you're like, I hope it all went well.
Yeah, in one piece without a free cap, right? But you know, when we talk about microkeratome days, I mean, the young surgeons hate it because it sounds so much like in the good old days, blah, blah, blah.
Right.
Yeah, they hate it.
But it's important to learn from that.
Oh, yeah.
I mean, it's kind of, I guess, maybe someone of my generation who's in their 50s thinks back of like the old, ceratomiliosis days and the frozen lenticules that are cryo-laid.
Yeah.
I mean, there's obviously a whole lot of advancement of this, but I mean, where we are now, we're so fortunate.
Oh, yes,
Now,
you're absolutely right.
Yeah, are you doing, for, let's say, corneal refractive surgery, are you doing mostly LASIK, PRK, trans PRK, or mostly lenticule-based surgery?
Okay. 90% of myopia go through SMILE, 85 to 90. The rest, 15.
Corneal lenticule extraction.
Yes, clicks.
Wow.
All right. And about 10 to 15 go through phakic IOLs.
Okay.
And a very small minority for trans PRKs. LASIK cases are reserved for hyperopia.
Okay.
And presbys.
What's the Presby treatment you're doing?
I do a Presby treatment called Presby Max, supplied by Schwin, Kleinostheim, Germany. I find it to be very easy to understand. It's easy to reverse, and the patients love it.
About how much range can you get? So let's say you have a 50-year-old patient come to see you, and the
-2.
common is you got a 50-year-old who says, I'm -2, and the 50-year-old says, just fix my distance vision. My near vision is great.
You're talking about you, right?
I'm -2. You got it. Look right there.
Yeah,
-2. Here we go. So what would you do for me?
Well, I would do a prolonged spectacle wear study. I might even go to contact lenses.
Okay.
I always trying to aim for -0.89 for the non-dominant eye.
Oh, interesting.
With enough negative spherical aberration induction in the non-dominant eye on the corneal vertex
to increase the depth of focus.
Yes.
Oh, interesting.
And the dominant eye, I would go with smile or click, sorry.
Yeah. I think,
And
you know what, that's a good point, because if I sometimes will wear contact lenses, not usually, but sometimes, I'll wear the full correction of -2 in my right eye,
yeah,
and I'll wear a -1 contact, therefore undercorrecting by 1 diopter on the left eye, and I'm pretty happy.
yeah, that works. But the negative spherical induction that is on the cornea will produce about, give or take, +1, 1.5 to +1 1/8 add. So
Also,
it's,
even more. So I
yes,
may get
even more.
even though the
Yeah,
anisotropy is, let's say, a diopter or 0.89 diopters,
yeah,
I may get even 1.5, 2 diopters of range out of that eye.
exactly. So they can read J1 easily.
That's probably better than what I'm doing now in the contact. Wow, that's great.
Yeah.
Those Schwin lasers. So you and I were together a couple months ago in Zagreb, Croatia,
Uh-huh.
at the Gabric Clinic, and had a great time. And
Oh yeah,
those
fantastic place.
yeah, those Schwin lasers, which we don't have in the USA, and I don't work with the company, I have no financial interest. Those are amazing.
Yeah,
The
they
Schwin,
are. They really are amazing.
yeah, the Schwin Autos is the femto, and the Schwin Ameris is the excimer.
Yes.
Tell me about your experience with those lasers.
Okay, I first started with the Amaris more than 10 years ago now. It was the Amaris 500, and then I worked up my way to 750, and now I'm working with the Amaris 1050 system. It's the speed, it's the repetition rate. It has a 7D eye tracker. It was the first 7D eye tracker to be installed in an excimer. But it's not just the hardware, it's the technical support that you get from the company. It's the software that is where Schwin really excels at. They're corneal wavefront guided, anterior corneal wavefront guided, total corneal wavefront guided, and total ocular wavefront guided ablations calculated from diagnostic devices such as the Sirius, the Caratron Scout, and now the MS39 and Paramis. Just phenomenal. I mean, I have cases where we have made keratoconics emmetropic. We have made folded and torn lenticules still in the pocket, and we've ablated it with trans-PRK on the anterior corneal surface to make all the higher order aberrations almost go away. We get a completely regular cornea, so we're regularizing all the irregularity that comes from a messed up procedure. In fact, I'm using the MS39 to create corneal wavefront guided ablation patterns before I go to cataract surgery on eyes that had previous LVC, but now end up with too much corneal high order aberrations, such as decentrations, too small optical zones. I mean, they have too much corneal coma, too much spherical aberration. And I just regularize all of that because I think even those patients should benefit from the enhanced IOL technology that we have in 2024. You see a small optical zone, decentered cornea from a LASIK 15 years ago, and you tell that patient, sorry, you can only have a monofocal. I mean, these guys are fast adapters. They're the ones who made LASIK possible back in the day. They were the first comers. So they really want spectacle independence. And if they have enough cornea, I would treat that cornea first to correct and regularize their highly irregular corneas, and then wait 3 months and then implant a premium IOL.
That's where an American surgeon like me is at a disadvantage. Because if I have a patient who comes to see me, and let's say they had prior laser vision correction 20 years ago with an older style laser, ablation's a little bit decentered, they've got a lot of high order aberrations from that, I'll leave their cornea alone, and then I'll say, well, to get the best visual performance, we should just have a monofocal lens. But you're saying, no, you're saying, let me first fix your cornea.
Exactly. I learned this from Dr. Samuel Alba Mosquera from Schwin Eye Tech Solutions, and also from Paulo Vinciguerra. I mean, he's amazing too. So this is the way to go on these aberrated corneas. But you know, the patient does have to wait about 3 months for the epithelium to regularize again, and that 3 months is quite painful for the patient. And more often than not, these corneal wavefront guided aberrations result in increased amounts of myopia because you're ablating the periphery of the cornea and trying to get rid of that positive spherical aberration. So they'll need glasses or spectacles for about 3 months. Yeah.
But it's worth the investment. You tell the
Oh,
patient,
yeah.
if you just do 3 months, bear with me,
Yep.
you're going to have a lifetime of great vision.
You know, saying that on the counseling desk in the office and living with the patient for 3 months is another story.
Those
You
are
know
two
what it
different
is.
things.
Yeah.
But I think it makes a lot more sense to me. Like, of course, instead of just saying, okay, leave your aberrated cornea alone, let's just do a monofocal lens, you say, no, let's fix your aberrated cornea.
Of course.
Let that equalize and stabilize for 3 months.
Yep.
Then we can do any of these presbyopic IOLs you want, and you're going to be thrilled.
Right. Absolutely. But I don't always promise them that you're getting a diffractive multifocal IOL. We'll look at what your cornea looks like, and then we may decide on an enhanced monofocal or the EDOF, but that will have to wait. It's really tricky because you don't want to overpromise from the beginning. You know, the saying goes, always underpromise and overdeliver.
Right. No, I have an interest in using all the new technology IOLs, whatever we can get in the USA. So, for example, this weekend, I do not consult for any of the companies that make presbyopic lenses, just putting that out there. But this last week, I've been putting in more and more of the J&J Technis Odyssey lenses. They're multifocal to get some experience. In the US, though, for EDOF, extended other focus lenses, we only have 3. We've got the Alcon Vivity, we have the J&J Symphony, the older one with the diffractive rings, and we have the B&L, formerly AccuFocus, IC8.
Yeah.
But you are also using, and I've heard this in multiple meetings around the world this year, because I've been to 21 countries this year.
I know. Amazing.
Tell me about the Technis Pure C lens. We don't have it.
God. Okay.
I need to learn. Teach me.
To start, since you were talking about financials, I am a consultant for Schwin and for Zeiss. But for any of the IOL companies, I do not have any financial relationships with.
Okay.
Deal. Right. Okay. When about, I think 2 years ago, I would implant Panoptics in the non-dominant eye. And the dominant eye of Vivity. And the lack of photic phenomena, or not the lack of, but less photic phenomena in the Vivity, in the dominant eye, made neuroadaptation much more pliable, much easier. And I thought, this is it. Okay, this is the end game. My patients are happy, I'm happy. And I thought that was the way to go. And then this year, we get Pure C. Pure C is, of those who you're not familiar with, is a refractive EDOF. It has a refractive ring about at 2 to 4 millimeters of the IOL, and it is so tolerable to remaining anisometropia, even astigmatism, and to some amount of corneal hyoid aberrations. This is a game changer, and we don't have the Odyssey yet. So we got the Pure C first in the Asia Pacific region, and you guys got the Odyssey first. But I don't know how good it is, the Odyssey, but they made Pure C so good with no photic phenomena that almost none. And this is the lens for refractive lens exchange. This is
really how much range are you getting out of it? How many diopters of range is it?
At first, I began implanting both emmetropically, or as near to emmetropia as possible, and I was getting J3, J4, and so not good enough in some patients. Of course, I was very cautious during my consultation periods, and then I started putting in a little myopia in the non-dominant eye. Now I'm going to, well, my go-to would be 3/4 of the diopter myopic. but now I'm pushing it to -1 and even -125 in some instances. And it is so tolerable. Now, Pure C, I think, is a synonym for tolerability. It's just, it's a game changer. It really is.
Well, I think that the technicians, optical engineers, and we as surgeons owe so much to the engineers who are behind all these technologies, whether it's the eyewall optical design or it's the femto and excimer lasers. The engineers, oh my gosh, they make our life so good. But I think so far I've only done a few Odyssey, less than 20. I'm still learning, but it seems to be pretty tolerant of a little bit of residual refractive error, either sphere or cylinder, which I think is very helpful for the patient to get good outcomes here. But so the Pure C is, again, it's refractive. So there are no diffractive rings.
No rings, no diffractive rings, only a refractive ring.
So that's about 2 to 4 millimeters the zone out of the 6 millimeter optic.
Right. So if you have a patient with an atonic pupil, 6 millimeters, I wouldn't advise it.
What about a smaller pupil? Because it kind of seems like the opposite. So, because when patients accommodate, they tend to have smaller pupils, right? Pupils.
Right. But if you get a patient in their 60s or 70s with a large atonic pupil that reacts very poorly even to light, not that they have any posterior segment pathology, I would not advocate any kind of EDOF or diffractive IOLs. But even in small pupils, they're performing so well.
But is the central 2 millimeters of the optic, that's distance or that's near?
They really are not
giving details
about that.
Very interesting.
But if I get an abrometry with the paramis, the center is aimed for emetropia or target gold diopter, and the refractive ring is for near.
Got it. And you're doing a little bit of mini monovision, so plano, emetropia in the one eye, dominant eye, and the non-dominant eye. You said about minus 0.75, maybe now -1, 1.25.
Yep.
And they're happy.
They're really happy.
So my question is, you get a 60-year-old patient comes to you, who's a plano presbyope. So the patient's entire life emetropic. Always have great distance vision, but because of age 60 and presbyopia, has very poor near vision. You would do bilateral refractive lens exchange, and the patient will be happy with this lens?
Well, I'd have to consider other things also, not only his or hers ocular anatomy, but his habitual things that he does every day. But I think I would be very confident in doing an RA bilaterally on such a patient, because remember, he's been presbyopic for 15 years.
Right.
Before Pure C, I was never this confident. I would actually, in the days before Pure C, so it's about a year ago, I would seriously contemplate Presbymax on the non-dominant eye, and leave the dominant eye alone. I would have done that, but now with Pure C, it's, again, as I said, it's a game changer.
So what's the spectrum then? So you've got a 48-year-old patient, a 50-year-old patient sees you. You say, no, let me just do Presbymax. Let me do the corneal ablation.
Yes.
And then at 60 or 65, you'll do IOL. When do you switch over?
Well, there is no, for all our surgeons, there is no predetermined graph or table or cutoff value. It's what the patient needs and wants.
Right.
So I try not to fight with the patient on his wantings, but also I don't want to give him the wrong solution to for his main problem. So it's not a predefined set of things. We need to think of a lot of things: his daily life, his amount of cortical opacity or nuclear cataracts, because they start to speed up in that age range. So it's not just one thing. I think it's not just age, but late 40s, early 50s, not too much of a myope or even hyperope, my go-to would be Presbymax.
Right.
Mid 50s and above, then we'll talk more about refractive lens exchange.
Yeah, I suppose you're right. It matters on what they're doing all day. If the patient's sitting there all day on a phone that's held 30 centimeters away, that's a lot different need than me, where I tend to use a computer at about 40, 50 centimeters away.
Of course, right.
So you got to elucidate, okay, how are you spending your whole day? Because for me, I actually do very little time per day on my phone. I'm mostly on a computer.
Yeah. So, I mean, you don't want to do a micro monovision or too much of a micro monovision of minus 125 with a pure C to a Gold Pro.
Right.
Right. You don't want to, you know, a computer analyst or a programmer, then that would be a good option. But, you know, so applying that kind of methodology and talking with the patient, trying to find out what he or she really wants, more chair time, I think is the most important thing to a successful outcome.
Yeah, that's the tough part. I mean, to be frank, I mean, the surgery tends to be the easy part. The chair time and patient education and setting reasonable patient expectations tends to be the hard part.
And you know what? I learned that from CataractCoach.com.
Yeah, we all learn together. I mean, even this podcast, like I'm sitting here writing down notes. I'm learning so much. Another thing I want to discuss with you is I saw your presentation a few years ago when we first started using these femtosecond lasers for let's say LASIK flaps or lenticule extraction, and we in the U.S. had like for the lenticule a much larger 5 millimeter incision to extract the lenticule. We had much higher energy levels. We were getting these OBLs or opaque bubble layers. And then I saw your presentation and yours looked so much better. And I thought, God, he's such an amazing surgeon. And you were told me afterwards that you use much less energy. So tell me how this has progressed, because you've constantly come down with the energy.
Okay. When we first started with Plex or Smile, it was then with Zeiss's Vision-Max 500. The bottom setting for pulse energy was 100 nanojoules.
Okay.
But the FDA clinical trials were set, I can't remember exactly, but I think it was the bottom was 135 nanojoules or even higher. I can't remember exactly. Now, the Vision-Max settings set by the FDA, the bottom settings, I believe, is 115 nanojoules. Okay. And back in 2017, we published in JRS and AJO that by lowering the pulse energy down to the most bottom setting back then, which was 100 nanojoules, we were achieving almost 20/20, more than 95% on POD one day.
A day after surgery.
Yeah, that's more than 95%. And also we took electron microphotographs and we did an atomic force microscopy study. And we found that the surface roughness of the lenticules was much, much less. This was back in 2017 with less pulse energy. But remember, the total dosage of energy that is entered into the cornea is not just about pulse energy. It's pulse energy and spot separation and track distance. So, and all these three come into play. So if you have a very small spot separation and a very small track distance, even with the same pulse energy, you're putting in much more total energy dosage into the cornea. And if this is sparse, it's vice versa. But there are also other factors that we need to consider. Number one, cap thickness. If the cap is thicker, then the energy transference is going to be a little less. And also, the amount of dioptric correction that you want to do. Let's say you were aiming for -1 diopter lenticule or -8 diopter lenticule. Now, the lenticule thickness will be different. And of course, this will also transference less into the deeper cornea with the same amount of energy. So there are multiple things that we really need to consider. And I'm just trying to find the optimal sweet spot for that. So for any given cornea, I should do this pulse energy at this spot separation with this track distance for a given amount of dioptric correction at a given cap thickness.
Yeah. So the presentation you showed when we were together in Croatia
Yeah.
was you're using such low energy. It's almost like it's just plasma doing it. Tell me about this.
Okay, all right. Now that article is with JRS right now, and keeping my fingers crossed, we'll be able to read about it. But getting back to the basics now, when we deliver energy
Okay.
into the cornea,
Right.
what happens is molecules are ionized. Now, if you go back to our school days, ionization is the loss of electrons and protons.
Okay.
Okay. Now, ionization occurs, and then more energy is delivered, and then more ionization occurs. This is called avalanche ionization.
Okay.
After that, plasma is formed. Plasma is the transference or transformation of matter into almost pure energy. So there is a boom, and plasma is formed. Now, with higher amounts of energy, immediately following this plasma formation, there is an expansion of gas cavitation. So there is plasma up to this big, but the gas cavitation with higher amounts of energy delivered into the cornea will be larger. So that's why you're breaking up the cornea, lamella, or you're trying to create the lenticule with not just the plasma, but with an expansive force, a mechanical force of gas cavitation. This is what we see as OBL.
Opaque bubble layer.
Opaque bubble layer in the cornea, in the lenticular surfaces, the anterior and posterior surfaces, when we ablate or create the lenticule with a femtosecond laser. Now, I've tried to lower and lower and lower the energy to a point almost 80 to 85 nanojoules. Now, this is with the VisuMax, because all these femtosecond lasers, you cannot compare head to head. With the VisuMax 800, we lowered it down to 80 and 85 nanojoules, and we found that during lenticule creation, all I could see was the side cuts.
Whoa.
There was almost zero OBL. So I didn't know whether I had created the lenticule or not at first.
You can't even see it being made.
You can't. You can only see like a sci-fi scan of the laser, and then you get a side cut, and then you get your incision.
Well, that must be such an incredibly smooth surface then.
And yes, we took atomic force microscopies and electron microscope photographs, and we found it to be much smoother than with higher nanojoules put into the IES.
So then better vision for the patient immediately.
Actually, no. On post day one, it's very comparable to those operated on with 100 nanojoules.
Okay.
But by week 2, we have better cumulative visual acuity, better percentage of eyes that were doing better than 20/16.
Wow.
Yeah. So, and what is, I think, more important is we were getting less inferior coma after CLEX, because the main problem with CLEX was the formation or the induction of high order aberrations, especially in inferior coma. And with less energy put into the cornea and using only plasma, almost pure plasma, to create that lenticule, we were getting much less corneal coma, and that was very, very surprising to us. And the good news,
neat. That's really, and so you had to adjust in the track as well in the spots.
Oh yes, oh yes, yes.
There's some secret sauce in there.
No, what about it's just physics. It's just physics. It's just like boiling water. You can boil water with your gas oven, or even a microwave, or wood stove. You just need to reach 100 degrees Celsius, and then entropy takes over, right?
Then you're done. Yeah.
Right, you're done. It's the laws of physics. Plasma CLEX is exactly the same. You just want to find that sweet spot, that Goldilocks zone, somewhere in every femtosecond laser system, that pulse energy, that spot separation, and that track distance. But always, not just these three, you always have to think about diopter correction and also cap thickness.
Wow. Now, you talked about this, the VisuMax. What about the Schwin laser, the Atos laser?
The Atos is also great. You get, eye center the treatment with the VisionMax with the triple centration method, I put 3 ink marks surrounding the first Purkinje, or the coaxial light reflex from the cornea, and that identifies the corneal vertex for me. Atos, you don't do that. You don't need to do it, it's just done, and it just takes that much more precision, and also it does a cyclostatic cyclotorsion control for us. So you really don't need to worry about a wrong astigmatic axis. Now,
wow, those engineers, wow.
Exactly. I mean, it's the Schwin Atos is amazing. It really is. It imports it directly from your diagnostics, so you don't have to do any of these transcription things that might go wrong. So you get a topographical pupillary offset of, let's say, 0.245678 down to 19 digits. It's automatically imported into the laser.
This is like data from like the MS-39.
MS-39, but you can also do it with the Sidious and the Paramus.
No, for Christmas this year, I want an MS-39. Can
yes,
someone
you
should.
This? I mean, MS-39 is now, if the Pentacam, the Galilei are giving information cross-sectionally.
Yeah.
With the Phoenix software of the MS-39, you are getting 3D continuous information. If you get this integrated into your practice, you'll know what I mean.
I'm looking forward to it. Now, tell me more about the tissue laser interaction with the laser-induced optical breakdown.
Right.
And the symmetric versus asymmetric spot and the track placement. Tell me about that.
Okay. Now, traditionally, the spot and tracks were symmetric, meaning, remember, we're hitting a spiral pattern, right?
Correct. Starting in the middle, going outward.
Yes. So one spot here and the adjacent laser spot, the distance between these two are called a spot distance.
Okay.
Now there's one raster going round, and then there's a next raster. So the difference between the distance between one raster and the next raster is called a track separation.
Got it.
Okay. Now, utilizing the spot and tracks, or you could increase the tracks, or you could decrease the tracks. You could increase the spots, or you could decrease the spots. Okay.
Sure.
Now we found by increasing the spots, there was less microcavitation from the previous bubble, interfering with the new laser pulse of the forwarding of the new laser pulse. So it's less microcavitation. If there is a burst of gas and then the new bubble falls on the gas, then it's not going to meet corneal. It's not going to meet fresh tissue.
Right.
Right. But since the distance of the spots are now a little further apart, you might get tissue bridges here. So this is taken up by the lessen the track distance. There's a spot placed here, taking care of that tissue bridge that is being created by the increased spot distance.
The spot from the neighboring track.
Yes.
Is bridging the two.
Yes.
Makes a lot of sense.
Yes. And I think
are you sure you're not an engineer also?
No, but most of my input is coming from working with engineers.
Yeah, because you have such their mindset is amazing, because most surgeons don't even think about all this stuff.
No, but I learned so much from my dear best friend, Samuel Arbor Mosquera. He is an engineer of the top notch, and he's always listening to you, always wanting to know what you want and what the patient wants. And through discussions with him and conversations with him in long emails, I've learned so much. So my thanks to you, Sam.
Well, can you tell him to please do a US FDA trial? We want the laser in the US.
No, I don't think you want to talk to Sam. I think you want to talk to Dominic, the CEO.
Okay, whoever. Just give me the laser. When I posted a picture on my Instagram when we were in Croatia together, and we spent a whole day watching Ivan Gabaric do beautiful surgery on the Schwin, and I just said, "Can I please have this laser in the U.S., please?"
He's an amazing surgeon.
Yeah, that was a neat setup. I'm just always amazed that at all the meetings I go to, I learn so much. Like this year has been The most I've learned in a year ever. I mean, seriously.
Wow. Well, that's because you've been to so many countries this year.
Yeah, it's easy when your kids are growing up. My kids are big and gone, and they've left the home, and they're doing their own things. And I have nothing but free time.
Oh,
But that's
wow.
fantastic. So your clinic now, you're doing, I guess, a lot of corneal refractive surgery. Tell me
Yes.
also about phakic IOLs. You're using these in a good percentage of patients as well.
About a decade ago, we were about 50-50 with iris close and posterior chamber ICLs.
Now 99% posterior chamber,
No,
100%.
now 100% ICLs, EVO, V4C. We actually published on AJO this year on the 10-year results outcomes of the V4C posterior chamber ICL.
Mm-hmm. And
After, they introduced the Aquaport, the
hole in the middle.
the hole in the middle. And we found 0 cases of cataract in 10 years.
Wow.
And
What was the end? How many patients in this 10 years?
I believe it was about, give or take, about 150.
Wow, that's fantastic.
Yeah, it was. I can't remember exactly. 150. So we found no. There was endothelial cell loss.
Yeah, I think with any implant, no matter what, you're gonna get that.
There was endothelial cell loss, but
was it a large percent or small?
Almost all. Almost all.
What percent loss? 5, 10?
About 15 to 20.
Okay.
Okay. And this was 10 years. But they leveled out after year 5.
Okay, interesting.
So it was the first 5 years that we saw a drop in endothelium density, and they dropped out. And I don't have the math. I can't remember the math exactly, but we did a piecewise regression to find that break point. And it's in the paper. I'm sorry, I don't remember it, but
okay.
It's there. And what we wanted to know was whether any pre-op variable could be associated with that endothelial cell loss, whether
like
it's
AC depth or something.
Yeah, AC depth, anything. So we put in a bunch of data, including AC depth, even curvature, CCT, lens thickness, everything, sulcus to sulcus, and we found nothing. Nothing was more strongly associated with endothelial cell loss than pre-op endothelial level itself.
Oh, interesting.
Right. So the less endothelial cell density they had pre-op, they would have more endothelial cell loss at 10 years.
Oh, wow.
And that's not just in numbers, that's a percentage.
Wow. I would not have guessed that, I guess.
No, nor I. I would never have guessed that either. So every time we see a patient wanting a phakic IOL walking in with 2300 cell density, we would advise against it now.
Oh, for sure.
Yeah.
That's interesting. So if they're starting off low and you lose 20% and you're 2300, now you're like 1800 and it could trend down. Yeah, that could be an issue.
And that's only 10 years. So we've always been talking about vaulting with ICLs. Yeah. Always about vaulting mechanics, but I think there are other important matters regarding ICLs, so including endothelial cell density. Now we have such better technology now, so we can. In fact, in Japan, they're working on an anterior chamber injection of endothelial stem cells.
I saw that. Amazing.
Yeah, it's amazing. So we have a lot of armaments to cover that, but still, it's not just about the vault, because the less the vault, the more cataracts, the higher the vault, the more acute angle closure. I don't think it's that easy anymore because of that hole. We're getting less and less cortical opacity or anterior capsular opacification after an ICL implant.
Yeah, I think even with a lower vault, meaning the back surface of the phakic lens is closer to the anterior lens capsule, I think because you have that small hole in the middle and you can aqueous flow through it, that kind of prevents the two from kind of interacting, even if the vault's very small.
Exactly, right.
I'd almost want to err on the side of slightly less vault as opposed to slightly more vault.
Oh no, we don't want to chicken out like that.
Yeah, how do you choose when the patient's right between? I don't know. How do you choose?
Well, I always opt for a larger vault And if
Okay.
it's too large, I would rotate it vertically.
Oh, sure, to decrease the vault. Sure, because the
Yes.
yeah, that makes a lot of sense.
All right.
But
So
interesting. So now you're doing also phakic lenses, but now also RLE. So are you doing a lot of cataract, or is it mostly RLE for your IOL placements?
RLE is about 15 to 20%.
Okay, and then the rest is cataract.
And rest of cataracts, yeah.
So you can't give up your cataract surgery skills yet. You still have to know how to chop a dense nucleus.
Oh no. We love that feeling, don't we? And recently I learned through CataractCoach.com the Rostelli Spin.
Oh my God, he's an amazing surgeon. If you don't know what I'm talking about, for our other listeners, Neto Rostelli from Brazil.
Oh my God,
is an incredible surgeon.
And I love his taste in music also.
Yeah. He has a great YouTube channel as well. It's fun.
Yeah.
It's fun to watch.
Yes. You know, I've been trying that.
And
I remove all the epinucleus, but I still get some cortex left over. So there is more work to be done there for me. But that technique, I think it's amazing.
Yeah, it's pretty cool. If you don't know what we're talking about, he works in a public health system in Brazil where he'll do at least 100 cataracts a day in 8 hours in one operating room.
Wow.
At least, if not often more. But his technique is to do a very, very efficient phaco. He'll spin the nucleus many, many times after hydrodissection. We're using
not just the nucleus.
Yeah, but it spins the epinucleus. It also loosens up all the cortex.
Yeah.
So then he's able to, in most cases, remove the entire nucleus, epinucleus, cortex only with the phaco probe.
Amazing.
Then the bag's empty. Then he just hydro implants an IOL, and he's done with the case.
It was shocking for me. I didn't know that would have been possible.
Yeah,
so I'm trying to learn that. Yeah, there are so many things that we need to learn.
Well, that's the neat part. It's like, you know what? That's like the saying goes: is when you're young and you've done only a few hundred cases, boy, you think you know everything. Then you do a few thousand cases, and you think, oh my gosh, I don't know that much. And then you do tens of thousands of cases, and you realize I know nothing. You finally accept reality.
Right.
Yes,
I know what you're talking about. Exactly.
But I mean, all these surgeries, they take years to learn, but a lifetime to master.
Yes.
No,
and hopefully we will master it before our days are over.
Yes, for sure. And then I'm looking forward to even these new technologies. I think on the IOL side, I think it's right. Please, someone, and I'm working with one company, but I want many companies trying to make a proper accommodating IOL. So it's time for my IOL surgery. I want back to accommodation.
Right. We are aware of a couple of companies working on this, and hopefully we'll get the technology when it's our time to get underneath the phaco.
Now, I got to ask you now, on the patient interaction side, a lot of your patients have had plastic surgery, and that the K-pop influence is huge worldwide, but also the K-plastic surgery now is amazing. Yes. These patients have very, very high expectations.
Oh, yes, that's right. You know, I have a couple of plastic surgery friends, and we were talking about patient satisfaction. And it was quite alarming to learn that from an ophthalmology clinic, more than 85% of patients are satisfied with their final vision.
Okay.
Sometimes you get dry eye, sometimes you get epithelial problems and whatever and whatnot, but more than 85% of patients are very satisfied with their surgery. Now, I told this to a plastic surgery guy, and that surgeon told me there are less than 8% of patient satisfaction after plastic surgery.
8?
Now, if you can satisfy 10% of your patients really satisfied, then you're a really successful plastic surgeon. Now, that's because we us ophthalmologists provide an objective thing, vision, quality vision, but vision. But beauty is in the eyes of the beholder.
So subjective.
It's so subjective.
Right.
It's very temporal also. So it's very, very difficult. But he told me also, because of that fact, they come back and back and back for more.
I guess
So
that's
once
good.
they've
That's
done
good
their
news.
eyes, they want to do their nose, they want to do their chin, they want to do their skin, etc.
That's it's just such a low percent. I mean, it sounds
Exactly.
like so much stress for the surgeon.
So they want just more and more and more. It's not like, oh, I don't like my nose anymore, I want you to put it back to its original form. It's not that. They want more. After a nose job, they want a lid job. And after a lid job, they want a chin job. And then they want to dismantle their entire dentistry to make this jawline look different. It's
Where does it end?
a very different industry, plastic surgery, I think.
Yeah, I think it's important to keep in mind an important lesson that a plastic surgeon taught me. And he says, we can make a pretty person even prettier.
Yeah.
But we can make an ugly person only less ugly. I thought, am I the ugly one? Are you talking to me? Hello. So yeah, that's very stressful. But then the patients see you. Let's say you get these patients, they've had their plastic procedures. Now they're looking better in the mirror, but now they want to see better. They have those same unrealistic expectations when it comes to you?
I don't think so, because of prior consultations and the demands for plastic surgery and the demand for ophthalmologists are quite different, because we have an objective thing, and their vision is not in the mind of the beholder. It's a qualitative thing that we can actually measure objectively, even quality of vision.
While I do have some patients who will tell me,
oh yes, we have some, don't we all? We have some. There's nothing wrong with their eyes, but you just don't want them to go to a different clinic.
They tell you, doctor, I know I see 20/20, but when is it going to be really sharp?
Oh, of course we have those. We will have a bunch of those, but so what do you tell them? You treat their dry eye first?
I said, results of surgery are 50% of what I do, my techniques, technologies, and I've delivered to you a perfect refractive outcome. And 50% is you and your tissues, your anatomy, your healing response. And we have to work together, and let's give this some time. That's kind of usually. But I'll tell you, the patients who've had in my clinic, our surgery centers in Beverly Hills, who've had a lot of plastic surgery, tend to be a lot easier going, because their goal is, they're much more concerned. If I see someone who comes in who's clearly had a lot of facial plastic surgery, I can tell they just want to be free from glasses because they think that wearing glasses makes them look old.
Yep.
And if there's some imperfections in the vision, some glare and halo at night, a little bit less contrast, they're okay. They don't mind, as long as they don't have to wear glasses.
Wow. But I wish I had more patients like those.
But I also tell them,
Beverly Hills, right?
But I also tell them, though, I said, Mr. or Mrs. Jones, you're 80 years old. You look amazing. You're doing well. You're healthy. You're 70 years old. I said, I'll make you see better, much better than you see now. But I can't give you the vision you had when you were 25 years old, any more so than your plastic surgeon can't make you look like you're 25 years old again. So let's be realistic here. And I find if I say it that way, they get it, and they're like, okay, we'll roll with it. Not too bad.
Okay. All right. Another lesson learned.
Another great part I learned. When a patient reports to you, doctor, and I see this and I see that, and sometimes I see this little floater and I see some at night, I always just say, well, thank you for letting me know. I appreciate that. That's it. Thanks for the feedback. I appreciate that. Let's keep an eye on that as you heal up more. Appreciate that.
Oh, that's good. That's good.
Because I treat it like, okay, you're giving me some good feedback. You're giving me some information how you're healing. And it's not necessarily a complaint. Because in medicine, we always say in medicine, what's the patient's chief complaint? Well, sometimes the patients don't really have a complaint. They just want to give you some feedback. So I stopped assuming that everything is a complaint. I started saying, oh, thanks for the feedback. That's it.
Okay, I'm starting that today.
Oh, so fun to chit chat with you. Look, I've learned a lot from you. I look forward to using some of these newer technology you're talking about, whether it's the new refractive EDOF lens, whether it's the new lasers, new technologies. Hopefully, Santa will bring me an MS-39 diagnostic device for Christmas. But I learned so much just by hanging out with you. Thank you again for doing this podcast.
Thank you for having me, Uday. Thanks very much. I've learned a lot.
Oh, it's been fun. I look forward to us meeting again in yet another country, doing lectures together.
Okay.
Again, amazing time. Keep up the good work and keep educating people like me about these newer techniques in especially keratofractive surgery.
Thank you. I'll see you in LA.
Oh, that's right. ACE is coming up for sure.
All right. Okay.
We'll have a good time.
All
and
right.
I want to remind our listeners and our viewers, remember, we got a new Cataract Coach podcast every single week. Apple, Amazon, Spotify, Google, wherever you find your podcast, you find the Cataract Coach podcast. And plus, of course, we have a new Cataract Coach video every single day, more than 2,400 days in a row and counting. So until next time, I'll catch you later.